Hello, everyone, and welcome. We are so excited to have you all here with us today to talk about new psychosocial interventions. And we have a wonderful lineup of speakers here for you all today that will be presenting on various topics. My name is Tess Thomas. I'm a pediatric psychologist at the University of Kentucky, and my co-chair, Annie Deisman-Thomas, is a clinical social worker at St. Michael's Hospital Unity Health, Toronto. We will have the session recorded, so we ask that if you have questions to please come up to the microphones, or you can put them into the app and I will read them for you. We are happy to welcome our first speaker, Jennifer Butcher, who is going to be talking to us today about single-item mental health monitoring, sensitivity and specificity of the distress thermometer in cystic fibrosis. Dr. Butcher is a clinical associate professor of pediatrics and a pediatric psychologist at the University of Michigan Health. I will hand it over to Jennifer now.
Thank you. Thank you for the kind introduction and for the invitation to speak today about some work that my center and I have been working on with being more efficient in our screening. Here's my disclosure. My other disclosure is that this is not an intervention, despite the title of the workshop, but hopefully it'll give you some other tools for your toolbox with your mental health screening. So as you all know, probably in this room, the recommendations for CF mental health screening are once yearly screening, and if the screening is positive, to follow up with re-screening at the next visit. This data shows how far we've come with our annual screening rates, which are over 80%. This is from the 2024 data. But as you see, the rescreening rates are much lower. And this is from the CFLN Mental Health iLab data, which is rescreening is about 61%. So when we think about what might get in the way, why are we doing so good with our annual screening but struggling with our rescreening? There's a few things that kind of come up over and over again. One of them, obviously, is the availability of a mental health provider to do the rescreening. We've done a really nice job with figuring out ways to get that annual screening done, but the rescreening, the intervention, I think is still some work in progress. Time in clinic, there's a lot of us in clinic and a lot of people to see patients, so sometimes rescreening for mental health may not take priority over other providers who might need to see a patient. And then I think we've learned at this conference and from talking with our patients that we ask them to do a lot. That questionnaire fatigue is real, right? We're bringing out more tools to our toolkit, which is really awesome for our patients and families, but it's a lot. Like, how do we prioritize what we do and how much we're asking them to answer in clinic? Our journey in our CF center, we're in pediatrics, and we, a few years ago, came up with our own pre-clinic screening questionnaire. We wanted to maximize patients' time. We wanted to tailor their care. So we all got together and we all came up with what are the most important things we want to know about what a patient might want to talk to us about today. So we all had a few items, mental health, respiratory care, equipment needs, and we developed our CF screening questionnaire. And we set it up as a Likert scale. So it would say, how much are you feeling sad today? And they would say 1 to 7. How much are you stressed about insurance today? 1 to 7. And what we really found as we started to look at our data is, one, it was a long questionnaire. It was a lot of answering of questions. But also we found that people tended to either respond all zeros, either they were just not reading the questions or really didn't have any areas of concern, or there was a lot of concern. So there was a lot of 6 or 7s. So what we started to think about is, are we really capturing maybe one sort of construct? And we started to think about it in terms of, distress is kind of what comes to mind. How much stress or distress is our patient or family feeling in this visit? Maybe that's more what we're capturing. So as we started to think about a different way to screen them, we came across the distress thermometer, which has been used a lot in cancer research and care. And when we think about distress, it's kind of a acute, short-term measure of, how are you kind of feeling today? And the National Comprehensive Cancer Network recommends using this with newly diagnosed cancer patients and then across time, and it really supported a lot of data in its use. So this is what the distress thermometer looks like. It's similar to a pain scale or other things we've used before, where it's a 0 to 10 rating. There's a lot of research in oncology and pediatric oncology and its usefulness and use. There's over 53 studies in non-oncology populations, including parents, preschool children, young adults, so across kind of the gamut, this has been used. And specifically, we were interested in pediatrics because that's our kind of area in my clinic. And it's really shown good sensitivity and specificity kind of across the pediatric population. So in pediatric oncology, it's 8.8 and above. So, and like I said, the distress thermometer can be even used with preschool children. It can be used with parents. So it's pretty well utilized. So we started to use the distress thermometer along with our preclinic questionnaire. So we have patients and families rate their distress when they come to clinic, and then they can still mark, like, what do you want to talk to us about today? So we still use that preclinic questionnaire. But we decided to try to look at it, right? Is this working the way we want it to? So we started to look at how we're using the distress thermometer. There's been different cutoffs for it used in different populations, but we wanted to know what's the best cutoff for our population. We also wanted to know, is it accurate in its diagnostic? So are people using the full scale? Is it capturing what we want it to capture? Is it sensitive? Is it specific? Are we capturing too many patients? Are we capturing missing patients, which is what we were really concerned about? And then, is it associated with some of the things we'd expect it to be? So are people expressing more distress when they're having more physical symptoms, for instance? So we looked at our data and did a retrospective chart review of about about a year of our data for our patients and the patients who filled out the PHQ-9, GAD-7, and distress thermometer in one visit. We also looked at the relevant medical variables and demographic variables. And we found that we were capturing about 82% of our patients. So we had an N of 93 out of 113. So these are patients that completed the distress thermometer and the PHQ-9 and GAD-7 in one visit. And this is pretty reflective of our patient population, this information. We're a peds clinic, so our kids are generally pretty healthy. Most of them are on modulators. And the rates of elevated PHQ-9 in our population and GAD-7 are similar to what's been reported kind of more center-wide. Our overall distress thermometer rating was pretty low, so the average was 1.4. So that's not, so it makes you think like, okay, this might not be doing what we want it to do. And the range only went 0 to 8. So we wanted to look at that more. So the way that we looked at it a couple ways. One, like I mentioned before, is the diagnostic accuracy, and then what's the optimal cutoff value. And I just want to take a minute just to kind of review how we looked at this for those, to give people a refresher. So for diagnostic accuracy, you want to make sure patients are reporting kind of along the gamut of the scores. If you had a straight line, that would mean there's like no relationship. You want a nice curve where it suggests that you're capturing what you want to capture. And then you can use ROC curve analysis to look at what your optimal cutoff value is. So you have to think about, and I'll talk a little bit more about sensitivity and specificity, but you want to think about how can you maximize both of those things, which is often hard to do. So it's a little bit subjective in that way. One of the things we thought about is we really want to maximize our sensitivity. We don't want to miss kids, right? We want to make sure we're not missing safety issues, especially. So we looked at our data. We found actually the diagnostic accuracy was pretty high. So just to give you a sense of it, anything 0.8 and above is considered good. Anything 0.9 and above is considered excellent. And we chose a cutoff value of 2, which seems really low when you have a scale of 10, but that's similar to what a lot of the oncology research has found, that 2 or 3 is generally what the cutoff value they're using is. And then we wanted to look at sensitivity and specificity. So just a quick refresher for those. I know it always gets confusing. So sensitivity is the ability to detect a true positive. So you want to capture those people who are really showing the symptom or the construct that you're interested in. And in this case, we were using, again, the PHQ-9 and G87 as our gold standard that we were measuring it against. Sensitivity is the ability to detect a true positive, or sorry, a true negative. So you don't want to over capture people, right? You don't want to burden people with extra time who may not actually be having distress. And this is what our data found. Generally, we were around that 0.80 level, which is considered pretty good. Again, we are trying to balance the sensitivity and specificity among the two gold standard measures. So we kind of prioritize the PHQ-9 because that was more of, that's more of a safety issue. We want to make sure we are capturing those patients. And we found overall it looks pretty good. The other thing we wanted to pay attention to, though, is especially the false negatives and false positives. So we wanted to make sure we were not missing kids who may be in distress, right? So missing kids who especially might be having self-harm thoughts, right? So we looked at who are the kids that our distress thermometer would not capture, but was captured by the PHQ-9 or G87, having an elevated cutoff on those measures. We found it was 6 of our patients. In general, they reported mild or pretty low, moderate anxiety and depression symptoms, and no one reported self-harm thoughts. So we also found that there were 5 kids who we captured by the distress thermometer that weren't necessary, that wouldn't have been captured by the PHQ-9 and G87. So we need to look a little bit more at those patients in particular, but it may reflect like more acute physical symptoms, or it may reflect school distress. There's a lot of things on our preclinic questionnaire that we can kind of correlate to that might not be anxiety or depression. So this might be capturing a different sort of distress than mood or anxiety concerns. And then we wanted to start to look at a little bit more at our validity potentially of the distress thermometer in our patient populations. So we wanted to start by correlating it with physical health. It was related to FEV1% predicted values at a lowish level, but still a relationship there. We didn't find any relationship with BMI percentile, though. So in thinking about this measure, we have continued to incorporate it into our clinical care. Obviously, this is just a single center's data, but I think it shows a lot of promise of this as a quick measure for rescreening purposes, so another tool potentially to the toolbox. We had a pretty small sample size. One of the things we want to do kind of going forward, again, is looking at more qualitatively, like who are we capturing, who are we missing by this data, but also to kind of talk more with our patients and families over what they think about these questionnaires that we're having them do, both the distress thermometer and our yearly screening and our preclinic questionnaire, because it is a lot. And to really get a sense of, is this something that seems to be working for you, or how can we tweak it? Because I think that's important for us to look at. And then obviously kind of continuing to look at it over time or with a larger sample size and look at additional measures of validity. So things like, are they receiving mental health care, or kind of more real world issues, and kind of what they're marking as areas of distress. But overall, I would invite you guys to consider the distress thermometer as a potential quick rescreening instrument, potentially in cystic fibrosis. It's pretty easy to administer. It's showing some initial psychometrics, at least with one group of patient population. But overall, I think, and I think it's important for us to have a flexible toolbox of different items and different questionnaires and things, so that we can really tailor, just like we try to tailor our care that we provide to our patients, to tailor what we do as a clinic, right? What works for us. And this is something that we found that's working pretty well for us and our patient population. Because I really think that we've come so far with the way that we've done the annual screenings, but the rescreening, the intervention, we have so much more we can do and so much more improvements we can make there. Here's my references. And then, of course, I would like to acknowledge my awesome team and my collaborators. Kathy, our clinic coordinator, Sydney was one of our research assistants, and Julie and Gabby, who are my colleagues in social work. Tara and Heather, our awesome patient family collaborators, and then Dr. Filbrin and Dr. Nasser, who are physician colleagues. And then, of course, we wouldn't have any of this data or really be here without the generosity of our patients and families for working with us in all this and putting up with all the questions we're asking them and all the things we're adding to their own, what they have to do when they come to clinic. And hopefully that, over time, we'll continue to figure out the best way to continue to work together. So thank you very much, and I'm happy to take any questions that you have.
All right, wonderful. So we've got about 5 minutes for questions, and I've got one that's already come in through the app. Please feel free to put your questions in the app or step up to either of the microphones in the aisles. So I will go ahead and kick us off with the first question that has come through, which is, have you considered the relationship with BMI could be curvilinear, with more distress for those significantly over or underweight?
That is an awesome thought. And I think that is something definitely we should be looking at, because we're seeing both ends of the spectrum now, which is so cool to see. I think in peds, we might see less of the upper end, but certainly that could be the relationship could be not a direct linear relationship. So thank you for that comment, whoever made it.
Okay, and our next question is, do you think the distress thermometer would be helpful for the adult population?
Yeah, it has been used more often in adults. So if you just do a search of distress thermometer, it's pretty widely used. It's used worldwide. Like I said, most often in oncology, but a lot of oncology populations, I think it's been used a little bit in geriatrics too. So I think it's something applicable across the board. I think we in pediatrics have to pay more attention to how well can our little ones rate their distress versus adults, but I think it's definitely applicable in adults, and it has been validated with non-CF populations.
Okay, our next question is, do we know if there is any data on responsiveness to intervention for the single item scale?
So is the distress thermometer sensitive to treatment? Can it be used as a treatment outcome variable? Is that, I know we don't have any other context to the question.
That's my interpretation.
Yeah. I don't. I think that that is not an area I have looked into, so I can't really answer that question. I think it could have applicability. I think when you're doing treatment outcome, though, you might want a broader range of items. It's depending on what you're targeting in treatment. Your treatment, generally, you're going to show more outcomes targeted to what your intervention is, right? So if you're working specifically on sleep, you probably want to have more specific information about that. But I think this could be used and could be looked at for that. I know that over time, when they look at patients with cancer who have used it, and their distress is highest at diagnosis, and then it tends to go down, which you'd kind of expect to see that relationship. So it does change over time with circumstances, but I don't know about intervention specifically.
Okay. And did you assess child report only or caregiver report as well?
So this is just our patient report, so 12 and up. So we see patients until right before they turn 22. So our range is just the 12 to 22. But and we were just looking at our kids who did the PHQ-9 and G87, so that limited us to the age of 12. And we haven't looked at our younger data. We do have parents rate their distress. We haven't looked at that data yet, though. Thank you very much.
So our next speaker is Dr. Alexandra Quittner. She is a senior scientist at the Joe DiMaggio CF Pulmonary and Sleep Center. Dr. Quittner is internationally recognized researcher who developed the first CF-specific quality of life measure used worldwide. Her work has transformed how we understand and address mental health in CF, and she continues to lead national efforts to bring mental health screening and support into everyday CF care.
Oh, thank you so much for that beautiful introduction. And I'm so happy to see all of you here this morning. Thank you so much to the conference chairs for inviting me. I'm going to kind of go in the opposite way of what Jennifer was talking about and actually talk about a new screener that we might add to our annual screening efforts. The development of a general mental health screener, the GEM-CF, which assesses other mental health comorbidities other than depression and anxiety. And from those data, we also developed a modulator side effects measure. The other thing I must do is really do a shout out to my wonderful co-PI, Dr. Beth Smith. She has been a leader in this work all the way along. And we have a huge team of people working on this. Here are my disclosures. Okay, growing evidence suggests that adults with CF experience mental health comorbidities in addition to anxiety and depression. I'm sure you're all noticing this in clinic. You might have someone who's abusing substances, having body image concerns, stressors related to taking modulators, and they cause distress and impact CF management, adherence, and health-related quality of life. We did a 3-phase study, a classic measurement study to develop a new screener. And I'm going to present the first 2 phases, but emphasize the last phase, which is a preliminary psychometric validation. So this mental health screener includes medical comorbidities such as traumatic stress and insomnia. And the side effects include those kind of classic ones we've been assessing: disruptions in sleep, cognition, and mood. Now, because we had these amazing community advisors in our group, in our team, including Casey White and Dr. Edward Kanda, they suggested that we needed to include measures of resilience and hope. And this was really something we hadn't considered, and I have to give them a huge shout out for asking us to really consider that and look at that as a mediating or buffering variable in terms of mental health concerns. So we added the Hope Index and the CD risk, both very brief measures of hope and resilience. So I'm going to show you the psychometric properties also in phase 3 of 54 adults with CF. This was a mental health research prioritization survey, and I believe it's under review. And it included 1,045 CF community members, both people with CF as well as providers. And a large percentage, 30 to 80%, endorsed the need to address comorbidities like body image, substance misuse, medical traumatic stress. And to understand the side effects of these modulators was also high priority. So here are some of the comorbidities. Most of these are single center studies looking at body image or substance misuse, but look at the potential impact they have. If we just focus on substance misuse, 24% in one study reported heavy alcohol use, binge drinking, and look at its impact. They had higher symptoms of depression and anxiety, no-showed to clinic more often, and were at risk for CF-related diabetes. We also have learned a lot about procedural anxiety and medical traumatic stress, which is very common. 76% in one study reported needle-related distress. So right now we're missing some of these mental health comorbidities, and we would like to include them. So these are the phases, classic phases coming from the FDA guidance on patient-reported outcomes, and we also adhere to the Cosman guidelines on the development of PROMs. So 3 phases: concept elicitation, open-ended qualitative interviews, what's important to the adults you're interviewing, what kinds of mental health concerns do they have, a draft items, and then cognitive testing of those items with a different sample, and finally coming back for a preliminary psychometric validation. We had a wonderful contacts that we elicited, adults from all over the United States. We used all of these resources and snowballing. So if someone who was diverse, an adult with CF, we asked them if they might recommend a friend or another colleague who also might fit the study criteria. So we really drew from a very diverse array of resources to get an enriched sample. Looking at our sample, this is phase 1, 2, and 3, just focusing on the bolded areas, you can see we actually were very successful in getting a diverse sample in terms of gender, range of age, all the way from 18 to 74, Race and ethnicity were included much more than in a typical CF study. And we had a mix of people on or not on modulators and a large percentage who met the federal poverty guidelines. So this is truly an enriched sample, and we have to keep in mind they may be more vulnerable to mental health comorbidities because of their socioeconomic or minoritized conditions. So aim 1 was a qualitative interview. We first primed them with the PHQ-4 about depression and anxiety, and then said, aside from that, what other mental health concerns do you have? We also asked them to rate the impact, and we coded everything using in vivo with very high inter-rater agreement. So this is the thematic coding of phase 1. And so just to see, procedural anxiety was endorsed by 90% of our adults. Disrupted sleep, negative body image, 85%. And then look at trauma and PTSD. So these are things we're not currently addressing in our mental health care for people with CF. And I think we would all agree these are really important and could impact quality of life and functioning. These are the modulator side effects that were elicited, and I don't think this will surprise anyone. In fact, looking at the top 5 adults had discontinued their ETI because of side effects. Uncertainty about the future, body image, brain fog, cognitive issues, insomnia. We've heard a lot about these in this conference and in conferences previously. So then in round 2, the second phase, we did cognitive testing, 2 rounds of cognitive testing with new adults to create the final draft instruments. And you can see their modulator status. And for those who changed modulator use, some increased or decreased dose, changed the timing. So this is our phase 2 sample. So from that sample, we did an iterative process looking at item writing, and this is our final measure. I'm happy to send it to you. I gave out probably 300 or 400 at the European meeting, and I'm using this actually in my clinic. I'm in an adult clinic where I work. Here's the modulator side effects. I use this every clinic visit with my adults, and this is a very good tool. I collaborate with my pulmonologist. We look at how frequent these side effects are happening, and we often flip a dose, alter the dose, lower a dose, and it's been an incredible guide. Then I can retest them and see whether this change in dosing has relieved them of these side effects. So this is really critical here. And even though we're going to be doing a big national validation, I'm using this in my clinic routinely every visit, and it has been an incredible guide for us. Finally, our last phase, phase 3, is the psychometric testing, which I always love. And just to let you know, over 50% of our adults had 6 or more of these concerns. So it's not like they just had substance misuse. They might have several concerns. And this is the impact rating and the ranking. So stress of CF, sleep, insomnia, cognitive, you can read those. Again, procedural anxiety, medical traumatic stress come to the top. So the results of our psychometric analysis, Hearth Hope Index, just look at that mean for our adults with CF, 37.2. The cut point on this score for positive hope is 34. So our adults are expressing a lot of hope. Again, thank you to Casey White and Dr. Kenda for this suggestion to include these tools. Also, the CD risk, look at the mean in our sample, 27.1, and they're above the cutoff, meaning, again, they have resilience. And as we begin to measure mental health more broadly, it would be so interesting to see that if those adults who have high resilience have less of an impact of those mental health concerns. The reliability coefficients are awesome. Look at the internal consistency. It's wonderful for exposure, for impact ratings, and domain level reliability. So psychometrics really looked phenomenal. Now look at the convergent validity. And if you want to just go to the bottom, the GEMS mod SE is, of course, positively correlated with PHQ-9. So if you're having more side effects, you're going to endorse likely more symptoms of depression. And look at the GAD-7. Similarly, you're more anxious if you're also having more side effects. Now, run across and look at the CD risk. It's just what you would expect, a negative correlation. So the more resilience I have, the less that's impacting me. So the convergent validity was very supportive of all of these tools and helped us to craft the next phase. So in conclusion, qualitative results suggested mental health comorbidities are highly prevalent and very impactful. There are strategies to recruit diverse samples in CF, and our goal in our next phase, a large national psychometric validation, will be to get a more representative national sample, not enriching as much for diversity. Also, 85% of adults said that this was very feasible to do in clinic. It's less than 5 minutes and very helpful. And the preliminary psychometrics were excellent. The tool is reliable and valid. And our next step is, of course, this large national psychometric validation, which we're so excited that the CF Foundation has funded. Now, I can see my slide got a little bit strange over here, but here is our current screening algorithms, right? We screen at least annually by the mental health coordinator. The PHQ-9 gets 7, and it's a little messed up, but you can see I added the GEMS CF to that screening protocol. It would add 5 minutes annually. And from my perspective, to be able to identify these at-risk features, these mental health concerns that are impacting our adults is so important that I would want to spend 5 minutes doing it. And so it's a little contrary to the idea they're overloaded, but I can tell you that by identifying some of these risk factors, we have been able to implement interventions that have been really valuable for our adults with CF. I also want to show you our next phase, which is a national psychometric validation. Now we're going for a broad national sample. We have Dr. C.J. Bathgate at National Jewish, Dr. Amanda Bruce at University of Kansas Medical Center, Dr. Anna Georgiopoulos at Mass General, Dr. Beth Smith at Buffalo, and there's me way down there in Florida. And what you can see is we're trying to get a geographically representative sample. Each center will enroll 50 adults with CF, and we will have a population of 250 to do some really cool psychometric analyses. And we are just so excited. We're working on the IRB now. So we thank the foundation for funding us. We're so excited to be doing this. Here's our national psychometric validation plan. It's a really comprehensive battery. There are the core measures that all 250 adults will take. It takes about 50 minutes, and we will reimburse them $75 gift card. Then we used a very innovative technique of using a planned missing data analysis, which is a very cool design if you want to reduce respondent burden. And so half of our sample will do set A, half of our sample will do set B, and then in phase 2, we will take 100, again, all of these randomly selected, to do the mini diagnostic interview, which some of you may be familiar with, and the symbol digit modality test, which is a brief cognitive screener. So this is our plan to do a very comprehensive, in-depth psychometric validation of our tool. This is the core battery and all of the measures in case you were wondering what they are. And finally, feel free, if you would like to obtain any of these screeners, I would be happy to send them to you. And finally, I have to say thank you so much to our incredible team. I would love to just name everybody. I particularly want to point out our community partners. They gave us insights that nobody else can give us. We, of course, are providers and researchers in CF, but we don't have CF. We do not know what that lived experience is like. And their input has absolutely shaped this study in a new direction that I think will provide benefits for all. So I want to point out Dr. Edward Kanda, Dr. Nowakowski, Laura Tillman, our community representative also, and Casey White. And of course, we want to thank the adults with CF for their contributions to this study. Thank you. I made it on time.
Okay, I have several related questions here about whether or not there is plans or if the GEMS can be used in pediatrics. And if not, what is the earliest age recommended?
Oh, that's such a great question. We're using, the GEMS CF was developed with 18 and up, but 18 all the way into their 70s. But it is not the tool I would use with pediatric age groups. You know, when you develop a patient-reported outcome, your responsibility is to go to that population themselves and elicit qualitative data about their mental health concerns. That is really the fundamental step of a patient-reported outcome. So you can't take the input from the interviews of adults and extend them downward to children or adolescents. That's just not the way it works. And we develop the best tools when we follow this type of guidance. We are, however, funded to do TIDES 2.0, which is going to look at children from 18 months through 11 years, and we will be testing and trying to identify the best screening tools for this younger age group. So there are 16 centers enrolled in TIDES 2.0. We also are funded in Italy, and that will help us to identify tools that are appropriate for younger children.
Thank you. And to clarify, specifically the GEMS modulator measure, can that be used in adolescents?
You know, I think that one might be able to be used in teenagers. I use it right now sometimes with teenagers, but I've sort of adapted it for pediatrics. I screen these modulator side effects every visit. I know everyone's like, we don't have time, et cetera. But these modulator side effects are really upending our care, really affecting people. So I take that 5 minutes to screen, and then we know what's going on. Some are switching to a lift track because their side effects are so bad on Trikafta that we want to switch them. And we have the data to show that. Then we're going to have the data on a lift track. So I think you should look at the screener and see whether you think it's appropriate. I use it as a discussion tool. I don't just give it to them. I come in the room, it's literally 5 minutes, and we go through the questions. So if they say I'm struggling to get to sleep, I ask them, what's happening? And if they say my brain won't turn off, I have racing thoughts, that's really informative for me, because then I'm suspecting the evening dose is a problem. And so really, I'd use it as a discussion tool, and they're used to doing it, and they want to tell me their experience and what's going on with them. So we have found that we can integrate it really easily into our clinic. It's become a mainstay of our practice in both an adult and pediatric center.
Okay. And what has been the patient response to being screened for hope and resiliency? Have there been any negative reactions or claims of survey fatigue?
Oh, that's interesting. Well, we don't know how they felt about it. We did include it in the battery. This was part of their study, but we didn't get direct feedback about how they felt about hope and resilience. But I can tell you, just from talking to people with CF, they don't want you to underestimate their strength, their fortitude, their resilience. So we haven't queried people directly. How did you feel about filling out the hope and resilience scale? But I can tell you our advisors have CF and they think it's critically important. And I also believe that this is something critically important to identify strengths as well as weaknesses. Of course, we have vulnerabilities. We all struggle with stress or certain kinds of mental health concerns. But if we're strong and resilient, have good social support networks, have good friends and family support, we can overcome those things. And just look at the life of CF and how our adults have coped. It's pretty remarkable. So I haven't gotten direct feedback, but I would say that they would feel that recognizes their strengths and it's important to include. Hi, Addie.
Hi, Addie Cuneo from UCSF. This is very exciting. Thank you for sharing it with us today. I'm wondering a little bit about, you spoke about adding it in addition to the PHQ-9 GAD-7. If you think very long-term, broad picture, do you think that there's ever a possibility that this could be part of a tiered system where we just do the GEMS, and then if there are certain questions that are positive, we go into more depth with the GAD-7 and PHQ-9?
That's a really interesting possibility. One thing that might be a little bit of a concern on doing it that way is that we really didn't put those depression items or anxiety items in this. This was really seen as added to PHQ-9 GAD-7. So it's not going to include, we got lots of symptoms of depression in the qualitative, but we purposely excluded those. For example, suicidality came up a lot, but since we knew it was on the PHQ-9, we did not put it into the GEMS screener. So I think it's missing those essential components of depression and anxiety that most of you are probably really focused on.
Yeah,
it's a great idea
though. Okay. Well, I think we have time for one more of these questions. And then if we have some more time at the end, we may ask the remaining ones.
Sure.
But someone would like to know, how do you help patients differentiate between their mental health symptoms from side effects of modulators, especially those who have been on AGMT long term?
Oh, that's a wonderful question. How do you differentiate? Sometimes I struggle with that, right? Like they're having a lot of side effects on the modulator, and some of them really mimic depression and anxiety. A few things I can do. I can go back in the record, since we screen every visit and we enter all the data into Epic. I can go back and see whether depression and anxiety is sort of a long-term phenomenon for them. Yeah, I think that's a really good question, and I'm not sure, how we would address it.
Thank you.
Okay.
Our next speaker is Dr. Amanda Bruce. She is a clinical psychologist and associate professor at the University of Kansas Medical Center. She's been part of the adult CF care team since 2016 and leads research through the CF Foundation's Success with Therapies Research Consortium. Her work focuses on how people make decisions, manage their treatments, and cope with the challenges of having chronic illnesses like CF and multiple sclerosis.
Thank you so much, Annie. I'm honored to be here today. It's great to see you all here in this room. And I'm excited to share with you some of the work that our team has been doing the past several years. Here are my disclosures. I like to put the thank you slide at the beginning, just to acknowledge right up front how this work would not happen without teamwork. And I'd like to call out Dr. Deborah Friedman as my co-PI on the studies that I'm going to talk about today. Also, definitely need to thank the community participants, right? As we've heard, the research and the work that we're hearing about today would not be possible without people generously volunteering their time. So what we're going to talk about today is a little bit about the need. I'm going to make a plea that pain is problematic in CF, and this is something that needs to be addressed. I'll talk about our process in terms of conducting these in-depth qualitative interviews with people living with pain and CF that led us to develop an intervention, a coping program for adults who are living with both CF and pain. I'll talk about our outcomes from the pilot study and then where we go from here. So when I used to teach undergraduate classes, I taught a capstone course in psychology, and we would do a whole unit on pain to kind of illustrate the mind-body dichotomy. And so I would actually have students, before we start, write out a definition for pain. I contemplated that today, having you all do it, but I won't. This is from the International Association for the Study of Pain. They define pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Emotional pain, if your pet dies, that's emotional pain, right? Physical pain, if you stub your toe, those are pretty easy to differentiate. But a lot of times what we see is that emotional pain and physical pain overlap, they interact with each other, they contribute to one another, and there's a physiological reason for that. The same brain areas that process physical pain are also responsible for processing emotional pain. And so it's no surprise that when a person is experiencing pain for a prolonged period of time, that line between emotional pain and physical pain gets blurry. For folks living with CF, you can see here this figure, all the different organ systems that are potentially impacted by pain. So the aspects of CF that lend themselves to discomfort and pain are many. If you think about people that you work with and that you sit with, you may have heard people talk about their awful sinus pain, right? Their migraines, their joint pain, their GI pain, right? And then, of course, there's the very common kind of chest pain, chest wall pain, or lung pain. Unfortunately, there are no psychosocial treatments available for pain for folks living with CF, despite the fact that we know that cognitive behavioral strategies can be helpful for people living with other diseases. Pain is prevalent in CF. Depending on what study you read, anywhere between 60 to 90% of adults living with CF have pain. So it's very common. And not surprisingly, it's associated with higher rates of depression, higher rates of anxiety, worse quality of life, difficulty maintaining a job, more CF exacerbations, and ultimately mortality. So we conducted qualitative interviews with 14 adults living with CF and pain, and we worked with Community Voice to recruit folks from across the country. All of the people we talked to said they have pain from multiple sources. I listed some here. Another theme that came up was that pain was a part of life with CF. They felt like the two were intertwined. In terms of how severe their pain, generally they said about a 5, right, for kind of just an everyday level of pain. But their worst pain, the mean reported, was about 8.6, so almost 9. I have quotes intermixed with these slides from our interviews that we did. One person said, "The fact that it doesn't let me live life the way I want to in the way I feel I am capable of, I always have to adjust my plans." People were glad to be asked about their pain. It was really interesting to do the interviews, and people were happy to tell their stories and to talk about, how they live day to day. Goes back to the idea of hope and resilience that we heard earlier that these folks have. We also asked them, what would be helpful, right? If we were to develop a coping intervention for living with pain and CF, what would you want to be included in it? And these were the themes that came out of that. Folks talked about how important it would be to address mental health. Someone said, it's hard to be in a good mood when you're hurting all the time. And your mood can affect your overall physical health. Again, this idea of how intertwined physical and emotional pain is. Folks also talked about the need to flexibly tailor the program to the individual. As you all know, you've worked with people with CF, there's not one certain type of CF, right? Some people have more GI problems. Some people have more lung problems. It's very heterogeneous, the condition. And so folks really emphasized we need to flexibly tailor this, make it very personalized. People wanted someone on their care team to deliver the intervention. They felt like they wanted specific CF-related modifications to the content. One example of that was for relaxation often, for people in general, you can do breathing exercises, right? And do deep breathing. However, for a person who's struggling to breathe deeply, or it's painful to breathe deeply, that's not a great idea for relaxation, right? So they said, leave out the deep breathing exercises. That's not helpful. They also talked about some barriers and then things that would make it more helpful. For example, telehealth, right? Having the ability to meet with people via telehealth is tremendously valuable. So from their feedback, we crafted a 3-session intervention. The sessions were about 45 minutes to an hour in length. They were all telehealth. We jammed a lot of information into each session. And when people were done, most of the people that went through our pilot study said, yeah, actually, I probably could have used a few more sessions. So maybe 3 wasn't enough, but we thought it was a good place to start. So the first session, we talked about understanding and acknowledging pain in CF. The second session, we talked about kind of behavioral strategies and then the cognitive aspects to improve comfort and well-being. And then the third session was about communication and advocating for yourself, not only with healthcare providers, but also with family members, friends, how to explain to someone when, you've committed to going out to dinner one night, but let's say you're having a day when your pain is particularly bad and you just can't make it, how to explain that to people. We showed them the biopsychosocial model of pain, which shows how there are so many different influences upon a person's pain. Everything from how much sleep you got the night before, your hydration status, your age. Folks, not surprisingly, said, as I've aged with CF, my pain gets worse. So age was definitely an important part of that. The psychological aspects and contributors to pain as well. Stress, right? If a person is having food insecurity or they're having trouble paying bills, like that's not going to help, right, with how they're feeling and their pain. The social aspect as well. How are other people responding to your pain? An easy way to think of this, when our daughters were little and toddling around and they would trip and fall, you've probably seen this, right? Sometimes the little kid will look up to the parent or caregiver and say, should I cry? Is this serious? Should I cry about falling down? Right? So like the social impact here definitely also plays a role in a person's pain. Session 2 talked about attitudes again, thinking about thinking. We talk about adaptive thoughts and helpful thoughts. This was very well articulated from a person in the interview portion of the study. I think the power of thought is really huge, and a lot of people don't realize how much that can affect everything. You can't let your CF determine your life because it doesn't rule you. We present to people, is there a way to think about your situation that's still true, right? We're not trying to do rose-colored glasses. We're not trying to do, everything is fine, I'm fine, right? It's important to acknowledge that things are hard sometimes. But can you think about it in a way that's more balanced, more helpful, and more gentle and kind towards yourself and others? We also talk about this fear avoidance cycle, which can be really challenging for people, right? If it hurts to walk, you might start walking less. You may stay home more. Dang it, and then you feel guilty about staying home more. And you kind of feel bad about yourself, and then you walk even less, and it just becomes this really awful cycle that people can get stuck in. So we talk to people about how to break that cycle and to try and, do things even when you may not want to do them. We also talk about pacing, how not to push yourself too hard past the point of perhaps healthiness. So we were curious to see if this intervention was feasible, acceptable, and we wanted to see what it did to pain, quality of life, and mental health. So we recruited 20 adults from 2 different centers, one in Boston, one in Kansas City. And we gave them a whole bunch of questionnaires, you can see here. We also wanted to see if they liked it, if they thought it was acceptable, if they finished the intervention, did they stop after one session? So we collected all of these measures. And our results were great. 100% of the people that we recruited finished all 3 sessions. So we felt great about retention. They liked it. They were satisfied with the intervention. We had a nice age range from 22 to 73, which is remarkable and amazing, right? That now we have people with CF that are 73. Their sources of pain were across the board. You can see here, lots of variety, lots of joint pain. And again, all of the people said, more than 2 sources of pain. I also want to point out here that they did the homework. Now we were careful not to call it homework. We called it practice because homework has such a negative connotation for most people. But they did it for 92.5% of the sessions. They did the practice, and the satisfaction was rated really high. What happened to the rest of these measures that we gave? So I have here effect sizes, and effect sizes are different than significance levels related to p-values. P-values depend a lot on the sample size. Effect sizes do not. You can see we had very promising results. We had large effect sizes, substantial increases in the CF coping self-efficacy scales of active stress management, cognitive coping. We had medium effect sizes with coping with daily self-care and acceptance and self-compassion. And we had small effect sizes for decreasing how interfering pain is for them and how much they catastrophize about their pain. Also, their pain intensity, depression, sleep disturbance, and anxiety showed small effects, but in the direction that we would hope. We also did brief interviews at the end to ask people, what was the most helpful? What did you like the best? This stands out. I think just being able to talk about my pain and feeling validated. I think validation goes a long way. So to summarize, the pilot study showed strong support for feasibility and acceptability of the PACE CF intervention and preliminary evidence of a positive impact for pain, quality of life, and mental health symptoms. Next up would be to do a randomized controlled trial, a larger trial of this intervention to see what we see with that. So the final slide I have is our contact information. And if you have any questions or comments, please reach out. And I will close with not my words, but the eloquence of someone we spoke with living with CF and pain. I think that with people with CF living longer, that's a huge thing that now we can research pain and focus more on that and quality of life. Thank you.
All right. Our first question is, do you know if teens or children endorse pain at similar rates to adults with CF?
That's an excellent question about teens and youth experiencing pain. I don't think it's as high. I don't know the exact numbers off the top of my head. I don't think it's as high as adults, though.
We had some data on that from our primary palliative care project, and it definitely is lower in adolescents and children than it is in adults, but still a common symptom.
Thank you.
All right. Do we know how prevalent? Oh, that's the same exact question. Sorry, it just popped up, but it's the same question. So we just answered that one.
Hi, so I work in CF and pain, so I'm obviously very interested in this. And I was curious, in your research, did you find any specific information about like how patients with CF, how they are experiencing pain or how they're talking about pain or the challenges that they have that are more specific or unique to CF versus patients with chronic pain in general or other pain-specific conditions?
It's an excellent question. And yes, I didn't have time to talk a lot about the other kind of qualitative findings, but one thing that was really interesting is people talked, like the majority of people talked about having a higher pain tolerance than the average person. I don't know if that mimics what you have. Yeah. Okay. And a lot of times we heard people say, people don't ask about my pain. And, if I talk about it, sometimes it's not very well received. If the care team maybe doesn't know what to do, or if they don't have someone, a pain specialist to refer them to. So is that similar to your?
Yeah, I think that makes a lot of sense. I think what's interesting about having pain in the context of CF is that I imagine there's maybe some dismissal sometimes. Oh, this is just part of your CF condition.
Yes.
And not taking extra time to explore the pain and all that's contributing or causing or, what's happening with it. I would also highlight, though, the whole thing about validation is huge in the pain community, especially with chronic pain. And so it makes a lot of sense that just this intervention, feeling heard, feeling supported was huge. So thank you so much for the work you're doing.
Oh, thanks for your comments. That was very well said. Yeah, even the qualitative interview portion that we did prior to the intervention study, those interviews themselves, people expressed gratitude for asking about their pain and like being able to tell their story and share their experience. So I think validation is a huge part of it.
Someone would like to know if it would be possible for other CF centers to be involved in the RCT portion.
Yeah, just email us. Yeah.
Okay, thank you.
Thanks so much.
All right, our next speaker for you today is Dr. CJ Bathgate, who is an associate professor of medicine and clinical health psychology at National Jewish Health's Adult Cystic Fibrosis Center in Denver. And she is the vice chair of the CFF's Multidisciplinary Mental Health Working Group, PRIME. And we are very excited to have her today to talk to us all about stress less and live more.
Hello, everyone. Good afternoon, almost. Here's the disclosure slide. I want to just start off with a story. And this might be one that a lot of clinicians in here are familiar with. So a patient comes in for a routine CF care visit. And I've just administered the GAD-7, the PHQ-9, and their scores are in the severe range. And I provide a brief intervention right then and there, and they might need some more comprehensive mental health support. It might be medication management, it might be therapy, or oftentimes it's a little bit of both. Here's the catch, though. Many of the patients, at least at our center, they come from rural mountain towns, hours away from our center. And ideally, we'd like to link them to local mental health care centers. But a lot of times, the community clinics and therapists have long wait lists. They're not accepting new patients, and our center is really big. And I'm not able to take on every person that needs help, but I can refer them to one of our lovely social workers who's here today, Rachel Stonecipher. And shout out to the social workers that are here in the audience. Our CF centers cannot function without y'all. So thank you for the collaborations that we have with all of you out here. And what Rachel can provide, which we're very lucky to have, are bridge services. And what bridge services are these very short 5 to 6 sessions max, where it's a bit of a stopgap, where she can help support them before they get to their longer term care, as she's trying to find them someplace that can support them. But a lot of patients we found, they have a hesitation of wanting to have to start fresh with another provider, right? They don't want to have to tell their story all over again. So that's got me thinking, that's where an intervention like Calm can come into place, right? It's a timely, effective option to reduce some symptoms in the meantime. And I'm going to explain to you what Calm is. I did a presentation on this last year. I'll tell you what it is for those of you that weren't here last year. But this is a great opportunity to be able to help people. And one of the things that popped up in my mind, the research question that we're here for today, is do people with severe symptoms of depression or anxiety, can they benefit from skills taught in Calm? And the reason why I want to focus on this group in particular is this group of people with severe symptoms, they often need help the most. And these are people that are often left out of randomized controlled trials. These are people that are often left out of clinical trials. And a lot of times these are people that I think sometimes people are scared. We don't know what to do with them. They need help right now. So how can some sort of manualized intervention that's taught to teach stress management, who you might not think, does that pair well with severe symptoms? Could something like this help? So coping and learning to manage stress. So at the top, this is the actual randomized controlled trial manuscript that was published previously. And so what is Calm? It's 6 telehealth sessions. This was done in 132 adults with CF across 3 geographically diverse centers at Johns Hopkins, University of North Carolina, and National Jewish Health. And the sessions cover the mind-body connection and really understanding how to activate the relaxation response, how our thoughts really do impact the way that we interact with the world, with our emotions, with our behavioral responses. We go over the ways to communicate with our loved ones and how to get the things that we need? How do we access the social support, not just asking for what we need, but the tangible social support, the emotional social support, those different types of social support that we need? How do we make sure that we're getting the self-care that we need? How do we manage those physical symptoms? So some of the things that Amanda was talking about, how do we manage our pain? How do we learn to meter out our day-to-day? How do we learn to conserve energy when we need it? And how do we learn how to expend it in the right way? What do we do when the thought work doesn't work? Right? Like, yeah, we've done the thought work, but like, I'm still really stressed out. I'm still experiencing these symptoms. So learning how to do above and beyond the problem solving, but some of these emotion focused coping strategies, and then learning how to set goals. And additionally, if after I've said this, you're thinking, okay, I want to learn how to do that. Like, I need that in my center. At the very end of this talk, I'm going to provide a QR code, which you can sign up to let me know what are some times that work well in your schedule. And I'm going to be able to see once you fill out a brief survey. I want to optimize it for the group. I'm going to be offering some free virtual trainings. So as a recap of what happened from the RCT that I presented last year, to orient you to this graph, the orange line represents the waitlist control group, and the blue line represents participants who received Calm immediately. And what we can see here is, compared to the waitlist group, those that received Calm immediately showed significantly greater reductions in depression based on PHQ-9 scores, both right after the program and at the 1-month follow-up with medium to large effect sizes. This was also the case for anxiety measured with the GAD-7, such that similar to the waitlist group, those that received such that compared to the waitlist group, those that received Calm immediately showed significantly greater reductions in the anxiety, both right after the program and then at the 1-month follow-up with medium effect sizes. And then, even though I didn't show it here on the screen, treatment gains for both outcomes were maintained at the 3-month follow-up and outlined in greater detail in the paper. So what that tells us is we know that Calm can lead to meaningful changes in only 6 sessions, not just in depression and anxiety, but also in reducing stress, improving coping skills, boosting vitality, which is a core part of someone's quality of life. And by teaching these practical skills in bite-sized pieces, Calm can really help ease people into the therapeutic process. And I think this can be really powerful for people who feel really unsure or skeptical about starting therapy. And we all know who those people are. You say the T word and they're like, I'm out. I'm not doing therapy. That's not for me. If you reframe it and you bill it as a set of skills, like, hey, I just want to give you some tools, right? I want to give you some tools. I want to give you some skills that you can take home right now. Let's just have a meetup, right? Not even a session. Let's just have a meetup where we can talk about some things to help you. I've got even a manual. I've got some things, or I've got a book that you can take home with some pictures that can help you. I think this can be really beneficial. And this is great for someone who hasn't even tried anything like this before or has trouble committing to things. We've also learned that when people with CF talk about things like thoughts of death, it doesn't always mean that they have an intent or a plan to commit suicide, right? This group, which tends to be those with severe symptoms, again, they're often excluded from trials or similar programs, yet they're the ones that need help the most. And unfortunately, when we see these mental health wait lists, they don't tend to screen for symptom severity. So whether your symptoms are mild, whether your symptoms are severe, you're often stuck waiting just the same. So which brings us back to the research question. Do people with severe symptoms of depression or anxiety benefit from skills taught in Calm? So to answer that research question, I went back to the Calm data and I looked at the primary outcomes of depression and anxiety, and I looked at them based on their symptom severity group. So it's grouped by normal range, mild, moderate, and severe, and I looked at their scores pre-post intervention and at the 1 and 3 month follow-up time points. So when we look at the sample, I was able to look at 121 people, and our sample was mostly in their mid-30s, predominantly female. We had 9% that were non-white, and education was more evenly split between those that completed a college degree and those that did not. We had 18% of the sample that identified as LGBTQAI, and almost half were married or common law. 60% of the participants were using psychotropic medication, 32% were in therapy. We had about 89% that were taking a modulator, which is very similar to the registry numbers. Average FEV1 was in the high 70s, and about a quarter had been admitted to the hospital in the past 6 months when we had collected data. So this is how people grouped out. On the left, we had their pre-intervention depression scores and where they fell with symptom severity. On the right, we have their pre-intervention anxiety scores in terms of symptom severity. And although depression, anxiety are comorbid, just because somebody might be moderate or severe in the depression category, that doesn't necessarily mean that they're moderate or severe in the anxiety category. So this isn't a 1-to-1 ratio, meaning somebody severe in depression doesn't mean that they're in the severe category for anxiety. So the groups that are highlighted in the red, those are the groups that I want us to pay attention to the most to answer our research question. So we're going to start here by looking at how participants who reported severe depression symptoms before receiving Calm changed over time on our key outcomes. So to orient you to the graphs, I try to do this in a way that makes sense, just if you're a color person and not loving looking at lots of scientific graphs. So each color represents a symptom severity. So green for normal, light green for mild, orange for moderate, red for severe. And so along the horizontal axis, you're going to see 4 time points. So you're going to see before the intervention, immediately after the intervention, and then at 1 month and 3-month follow-ups. And then along the top part, you're going to see right now we're looking at depression scores over time. So among individuals who started with severe depression, depression scores dropped significantly after completing Calm and stayed lower at all follow-up time points. And I think a key takeaway here is that by the end of the intervention, and even at the 1-month follow-up, the severe group's depression scores looked no different than those in the moderate group, just showing how much improvement had taken place. For anxiety scores, we also see a clear reduction for the severe group at all time points after Calm, with improvements so pronounced that after the intervention, the severe group's anxiety levels were similar to those of the moderate and the mild groups. So now let's reorient ourselves. These graphs look similar, but reorienting ourselves. The next set of graphs that I'm going to show you are these participants that at the start, they reported severe anxiety before starting Calm and how their symptoms changed over time on their key outcomes. So among those that started with severe anxiety before Calm, we saw significant reductions in their depression scores at every time point after the intervention, with improvements so pronounced that after Calm and at the 1-month follow-up, the severe groups was not significantly different from those in the moderate or mild groups. For anxiety, we also see reductions at all time points after Calm, such that after the intervention and at the 1-month follow-up, the severe group's anxiety levels did not differ from those in the moderate or the mild groups, suggesting significant benefits of Calm. So what are the limitations and considerations? So this is important to note that these are post hoc analyses, and that in the original randomized controlled trial, this wasn't specifically designed to examine how the severe group might respond differently than the other groups. We also looked at potential confounders to see if there were any baseline characteristics that were linked to the depression or anxiety severity groups. And so most factors like sex, race, social security benefits, modulator use, BMI, lung function, recent hospitalizations, so on and so forth, you can read the slide, they were not associated with symptom severity. But for depression severity, we found that as depression severity increased, the proportion of people that were unmarried, those that had not obtained a college degree, and those that were not working or in school for health-related reasons, that also increased. This also, though, aligns with research that we already know that marriage and higher education actually protects against stress, and that depression can also increase as one's health condition worsens. So this is something that we already know. For anxiety severity, we also found that younger individuals and those who were unmarried had increased anxiety severity. So a next step could be that we could run some models controlling for these variables to confirm that the symptom reductions that we're seeing in the severe group still remain the same of what we saw in the graphs. What I do think, though, is that the post hoc findings already show that calm reduces symptoms across all the groups from what you guys saw in the graphs. And the associations between certain characteristics and mood are well established in the literature. And so I think it's probably unlikely that they're going to have a major impact on the intervention's effectiveness in terms of driving change. But I think it's worth noting here. And I want you guys to know that I did think of this when I was reflecting on how I was looking at this research question, as any good researcher should do, because you should never think that your research is perfect, because it rarely is. Let's see. And another limitation is a small n in the severe group. We had 11 in the depression group and 16 for the anxiety group. So returning to the major research question today, do people with severe symptoms of depression or anxiety benefit from the skills taught in Calm? Yes, Calm reduces depression and anxiety in those with severe symptoms. The severe group had similar outcomes to lower severity groups post-Calm. The severe group, if we took a look at the graphs and we were to go back, I think they could benefit at the 3-month mark for a check-in, just to make sure that it's helping sustain progress, because there was kind of a little bit of a bump. Even though that they decreased over time, it would be beneficial to check in to make sure that they're sustaining progress and to make sure that they are linking up to that additional care, because this is not to say that, like, give them Calm and they're good to go. Definitely not. They need more care. This is meant to be something that you could give them in a short amount of time, something that could give them some skills to at least hold them over until they get something that's going to be more intensive, something that you could give them while their medication is becoming efficacious, something that you can give them so that they have something that they can do right away to help alleviate their symptoms. And in terms of implications for research and clinical work, I think this really begs the case. We need to continue to find ways to include severe cases in trials, because things can work. We shouldn't exclude them because we're scared to include them. And in clinical cases, Calm is a brief, effective tool for managing anxiety and depression symptoms. So what y'all have been waiting for is that QR code. So go ahead and get your phones out. It's absolutely socially appropriate to get your phone out right now. So get that out, go to the link. It's just going to bring you to a link that just has you just put in your name and just a couple quick questions. And then I have it in all the time zones just to tell me what your individual schedule looks like of when it would be great for you to get a training. And as any good researcher, I'm going to look at the mean and try to figure out when is a great time to capture the most of you guys at once so that I can give you guys a training and we can pay it forward. Because my biggest fear as a clinician, scientist, and intervention developer is to have this really incredible intervention that was developed, tested, reflected on, changed with patients and families, and just like have it sit on a shelf and have nobody use it. Like, what is the point of that? Like, the whole point is to get this out. And so I want y'all to be able to use it. I want you guys to be able to share this with your patients and families. And I just have to find a way to get that out there. So I'm just going to do this for free and like figure it out. So I know we do so much for free, but I mean, it is what it is right now at this point. So yeah, I just need to get it out to y'all. So please fill this out so I can figure out how to get this in your hands. And it comes with a provider manual. It comes with a participant workbook. It gives you a how-to. And so you literally go session by session, how-to tips. It walks you through everything. It is beautifully designed. The cover art is from one of our patients. So I hope that you all will join me in that training. That should happen in 2026. And here are all the people that helped me with this, including our patients, which I couldn't put because of HIPAA, but I gave them a big heart, and they know who they are in my heart. So thank you very much.
Okay, we have lots of great questions coming in. The first is a similar question for kind of consistent across our talks. Is Calm being adapted for peds or adolescents?
So whoever asked that question, come find me, because kind of similar to what Alexandra was saying, like, we need to make sure that we are doing this appropriately. Like, this was normed in adults. Like, the examples that I give throughout what's going on in here was made with patients, was designed for adults. This wasn't designed for kids. So if we want to use it with kids, we need to get clinicians and kids involved in this in order to make sure it works for kids. Because you don't want to just, like, they're not little adults, right? We can't use the same things for peds. So this was not designed for peds. This was not tested in peds. Could it work for adolescents? Perhaps. Again, the randomized controlled trial was with adults, and so I want to use that as a caveat. However, if you take the training, you could look at some of the skills. This is well-validated stuff in CBT, cognitive behavioral stress management, and you can see how you could adapt it.
And how is suicidality assessed and managed during Calm?
So we do ask the PHQ, the full PHQ-9, and for screening from the actual trials. And since this is going to be a clinical tool, this would be something that you as a clinician would be checking in with them on. And so you would handle it in the way that you would handle any suicidality. So again, as we're moving this from research into clinical practice, I would encourage you to handle it in the same way you would do in clinical practice.
Thank you very much for inspiring presentation. I was just wondering, what's the cause for difference between the immediate group and waiting list? These patients, they have been having these symptoms for such a long time, and they have also received a Calm, and I couldn't understand the difference between two groups.
That's a great question. So in order to show that Calm was the reason for the change, it's more of a study design issue. So going back to a randomized controlled trial, you have to randomize what people get the intervention right away and what people are not getting intervention, so that you can look at what's happening with somebody who's getting it right away versus somebody who's not getting any intervention. That group that was in the wait list, as soon as we measured them pre, post, and at the 1 month follow-up, as soon as that 1 month follow-up time period happened, they were able to, and the 3 month follow-up time period happened, they were able to get that intervention, and then we were able to measure them. So everybody that went through the randomized controlled trial was able to get the intervention. And
I mean, they wait in the patients in the waited list, they have also received the intervention.
the patients in the waiting list, they received the intervention after they were during the waitlist period. Yes. So the data that was shown there was the comparison between people that were waiting versus people that got the intervention right away. But eventually, it's in the paper as well, which is a great question. In order to be ethical, we gave it to everybody. Yes. And we have combined data that is presented in the paper because absolutely we want to give the intervention to everyone. We also needed to make sure to show that calm was working and it wasn't some other spurious factor that was happening. That's a great question. Thank you for that.
Someone said it's great to see focus on these groups with more severe mental health symptoms. And did those who completed CALM then go on to therapy in the community?
They did. And a lot of people that were very hesitant, again, those people that didn't want to go to capital T therapy, they actually afterwards was like, this was great. Like, can I keep going? And I think that's a testament to giving somebody a good experience. Like, I think that's what our role as a provider is I think a lot of people have these preconceived notions and expectations of what it's going to be like to go to therapy, right? They see stuff on TV or they hear stuff from friends. And all of us as providers, we have this opportunity to give them this wonderful experience. And if we can be that person that gives them that great experience, they might want to do more. And so I think CALM is presented in a way, not only with like a great acronym, right? Like, let's do this program called CALM. But if it's a skill building set of like, let's learn skills right now, it's 6 sessions. You can do it from the comfort of your home. You know, we can space it out. Like if you get hospitalized, like you can do it from your hospital bed. All of these things, it gives them an opportunity to like put them in charge of like when and where they want to do it. And they found it very favorable. So, yeah.
Someone has asked, I know that you've mentioned that this can be delivered virtually. Others would like to know if you could see this working in a group setting.
I would love to see this in a group setting. I would love to study that.
Great. And then there's just some people thanking you for doing the training, and many people saying they would love to collaborate with you.
I love
on the
that. And I
PEDS
can't
part.
wait to train you guys. I can't wait to see all your faces during the training. And I will be asking you to turn on your cameras because it makes it feel like I'm not talking out in the void. And I think connection is so important. So I look forward to seeing many of you in this audience during that training. And feel free to email me and let's chat about all these collaborations because that's what I'm here for.
I think it's on there already, but I thought I would step up in case it gets missed.
Yes.
What is the application for pediatrics, adolescents, young adults? We see patients up to 21 years old in my clinic. So
Yeah, you can use it for 21 and up. Absolutely. Those individuals were in our sample.
21 and up.
21, because we
As soon
we
as
were
they
an
turn
adult
on their
clinic.
21st birthday, we have to close them.
Yeah, so we included anyone 18 and up in our sample. So that would overlap, even though you're a peds clinic and
Sure.
they're still in the age range that was in our randomized controlled trial.
Great, thank you.
Yeah.
And then this is kind of a question for both you and Amanda. Someone is asking if you all think interventions like PACE and CALM would work with another chronic painful disease like sickle cell. This person works with both CF and sickle cell and believe that these interventions could benefit both.
Yes, I do think so. I think that what the tailoring was really tailoring it to a chronic health condition, and the examples that are used were very specific to CF. So I think if you could tweak some of the examples to insert chronic health condition of your choice, I absolutely think it could be used because these are techniques in the literature that have been well studied and are efficacious. So absolutely.
Great, thank you.
So now we are welcoming our final speaker, not the least by any means. This is Kelsey Logan, who is a senior specialist with the CF Foundation's Virtual Connection Program. She holds a master's in nonprofit administration and has spent the last 3 years creating a meaningful virtual experience that strengthens connections and support within the CF community. Now, living with CF herself and as a sibling to someone with CF, Kelsey brings a unique and deeply personal perspective to her work. We're so grateful for her ongoing contributions to CF care and for joining us today.
Thank you so much. Thank you, Annie and Tess, for inviting me. I really appreciate that. I have no disclosures. And good morning, everyone. Thank you for having me. As she said, my name is Kelsey Logan, and I work for the Cystic Fibrosis Foundation on the Support and Connections team. I'm here to talk about a virtual support program called CF Circles. As you all know today, there are more adults with CF than ever, thanks to the groundbreaking research and care that this conference highlights. Because of the risks of infection and care, research and adults with CF lack the ability to connect in person with others who understand their experience on a deep and personal level. Connection with peers and those who understand can be a source of social, emotional, and practical support. And CF Circles is one of the CF Foundation's programs that offers a space for adults with CF to share experiences and build meaningful connection. Before I dive into CF Circles, I'd like to highlight some additional support and connection programs. Each program listed is focused on providing opportunities for primarily adults with CF and sometimes families and caregivers to virtually connect with one another based on an individual's preference. On the one-to-one level, we have CF Peer Connect. CF Peer Connect provides peer support for adults with CF and family members ages 16 plus to talk one-on-one with someone who understands what they're going through. On the small groups level, we host CF circles, which are peer-led virtual discussions around highly specific topics and experiences. And then finally, we have community conferences, such as ResearchCon and BreatheCon, that are national virtual events where attendees can connect, share, and learn from others in the broader CF community. In 2022, CF Circles, which at the time was called Small Group Discussions, was piloted to address the needs of the community who are seeking connections between that one-on-one peer support that CF Peer Connect provides and the larger community events that community conferences support. The first year of the pilot, we hosted 6 virtual discussions and invited individuals who are already a part of our other virtual programs. We continued to pilot the program in 2023 with another 6 sessions on different topics. We distributed a survey to attendees after each session to assess the effectiveness of the discussions. The survey included questions such as whether the discussion met their expectations and whether they would be likely to attend a future session. All topics received over a 90% satisfaction rate, along with a high likelihood of participants returning for future discussions. In 2024, based off these high satisfaction ratings from attendees, as well as high conversion rates between registrants and attendees, we launched CF Circles into an official foundation program. CF Circles, as I said, are standalone, topic-driven small group discussions primarily for adults with CF. CF Circles create a space to virtually connect with other adults about their unique, shared CF experiences, such as not benefiting from modulators, living as a Black person with CF, or receiving a delayed CF diagnosis. Each discussion is led by trained members of the CF community who have direct experience with the discussion topic. The sessions are designed to be small and intimate, with no more than 10 participants in a breakout group, allowing for deeper connections and a stronger sense of conversation. So what makes CF Circles unique? Well, CF Circles fill a gap in support programs by addressing the broader CF community needs, including the needs of specific groups that have been historically underrepresented or underserved within the traditional CF community. For example, feedback from previous surveys told us that those who have had lung transplants, as well as those who are not eligible for modulators, both had distinct CF-related challenges, but each group felt disconnected from the CF community at large. We have created CF Circles around each of those topics to provide them with a space to gather with others who have similar experiences. By bringing together peers who share similar experiences and backgrounds, we're promoting a sense of commonality and specificity around challenging CF topics. Now, I'd like to share a little bit about the CF Circles session logistics. CF Circles are hosted on Zoom with at least 2 staff members from the CFF present. The program is 75 minutes long in total. As I mentioned, we use trained members of the CF community who have direct experience with the session topic. Our registration for CF Circles asks attendees if they're interested in facilitating, so we're often able to find our facilitators from those who are already planning to attend. We train facilitators by providing them with self-guided training modules that ensure that facilitators are well prepared to lead meaningful and respectful discussions. We also provide them with facilitator resources like sample language to rein in dominant voices, examples of prompting questions to start the conversations, as well as tech tips to help participants navigate Zoom. To keep the sessions small and intimate, we break the groups into small breakouts between 3 and 10 participants. We ask for information in the registration that can help inform how we break out the groups, such as age, connection to CF, years since lung transplants, or age of diagnosis. This categorization really helps the group participants by promoting camaraderie with others who they have the most in common with within a specific CF session topic. To gather feedback, a survey is sent to attendees in the post-discussion email. This email includes tailored resources like blog posts, specific CFF.org pages, appropriate guidelines and position papers, and a participant directory that shares attendees' names and emails of those who have opted into sharing their information with others after the session. After the discussion, facilitators are also asked to share any high-level takeaways or themes that came out of their breakout groups, and we use this information to identify potential topics for future CF sessions. Other ways that we identify topics for CF circles include community listening efforts from places like Community Voice survey results, community conference survey feedback, frequent CF Peer Connect topic requests, and insights from other foundation staff and departments. Additionally, we make sure to leave room for any emerging topics, focusing on novel issues or topics that may arise throughout the year. For instance, in 2024, post-event surveys from BreatheCon, which is a community conference that is just for adults with CF, revealed that body image was a frequently discussed topic. We added body image as a topic not long after BreatheCon to help address that community need. In 2024, we hosted 12 discussions, which you can see up on the screen there, with a total of 596 registrations. Of the 596 registrations, we had 288 attendees, 257 were adults with CF, and 31 identified themselves as caregivers. Caregivers in most instances were parents. Since the beginning of the pilot, the CF Circles program conversion rates of registrants to attendees has been relatively steady, with between 40 and 50% of registrants attending a CF Circle discussion. In 2024, the average was 48%. And I'd like to point out that this is pretty high for virtual support programs. Our community conferences like BreatheCon and ResearchCon tend to see conversion rates between 30 and 40%. Looking at specific session topics from 2024, those focused on life post-transplant and caregivers, advancing lung disease, and life as a Black person with CF and their caregivers had the highest rates of converting registrants into attendees. Some of the highest attendance numbers from 2024 included late or delayed diagnosis, life post-transplant, CF-related pain, as has been discussed earlier, and a discussion on CF-related diabetes. We held 2 sessions of late or delayed diagnosis, and each had high numbers of both attendees and registrants. And one takeaway that we saw from last year's data was that nearly 20% of participants were repeat attendees. That's notable because many attendees do not qualify to attend more than a couple of sessions each year, yet those who are able to are often repeating participants. So we have been very fortunate to have a high rate of return for our post-event surveys from attendees. I mentioned before that we have about a 50% conversion rate from registrants to attendees. We also have about a 50% conversion rate of attendees to survey respondents for post-event survey responses. So from those surveys, we have found that 93% of survey respondents said that their expectations of the CF circles were met. 89% felt welcomed into the conversation. 88% said that they would attend another CF circle discussion in the future. 86% felt a strong sense of belonging, and 85% felt comfortable sharing their perspectives. We also invite participants to share feedback for the facilitators and have developed specific questions for facilitators to reflect on their own experiences during the CF circles. Those responses to the surveys help us understand the impact that circles has on participants, what they're gaining from the experience, and what adjustments we need to make to better tailor the program to their needs. One of the tasks of the facilitators is to share with staff themes and topics that they heard during the discussion, as staff are not actually in the breakout rooms. We remain in the main room during Zoom. So the Life Without Modulators topic had participants that were ineligible to take modulators or were not able to benefit from modulators. Facilitators shared that participants felt they were being left behind and shared their disappointment in trying to take modulators, but not being able to tolerate them. They mentioned that they felt hope with new genetic therapies. The late diagnosis sessions each had themes focused on their emotions of being diagnosed at a later age. Some participants expressed frustration and shock. Some expressed relief that they finally had an answer for the years of symptoms that couldn't be explained. Others said they experienced grief at what could have been if they had been diagnosed earlier. Those who attended the Life as a Black Person with CF session shared that they don't always feel heard in the CF community. Caregivers in that group shared that they were glad to see others who look like them and have similar experiences. Sometimes the sessions focus more on practical advice. For CF-related diabetes discussion, the participants talked about their CGMs, managing their symptoms, and shared tips and tricks for those who are new to managing this additional CF-related burden. Our participants have shared many meaningful quotes in the post-event surveys that show the benefits that they have taken from CF circles. Some benefits include feelings of camaraderie, hope, belonging, as well as gaining knowledge or new perspectives around their disease. I'd like to share a few of these now. This person shared, "It more than met my expectations. It was great to hear other people's journeys that were similar to mine. Everyone was super friendly and open. I even got tips from other CFers tailored to my personal situation. Please do more of these. With Trikafta, there are going to be less and less of us post-transplant people, and we need ways to connect and support one another." Hearing others talk about things like small size, clubbed fingers, bloat, CF voice was really validating. These are things that I've struggled with one time or another, and we're all trying to do the best with the bodies that we have. Testimonials like these help us understand the benefits of CF circles from the community's point of view. In 2025, we have held 11 CF circles to date, with 3 sessions to be held later in the year. New topics this year include sexual health, navigating the financial impact of life with CF, life as a Hispanic person with CF, pain management, and life with GI issues. Looking ahead, we are committed to ongoing evaluations, making changes to the program to make sure that participants are making the most of their time with us. We'll continue to listen to feedback and track outcomes. CF Circles fills a critical gap in adult CF support by offering unique space for connection that just doesn't exist elsewhere in CF support programs. For many adults with CF, especially those in niche groups, CF Circles provides a rare opportunity to be seen, heard, and understood by those who truly just get it. Want to provide a QR code for you all to learn more about what CF Circles are coming up. Please visit CF Circles webpage at cff.org. You can also email me if you have questions about whether or not your folks would be eligible to attend. You can see my email there. It's klogan@cff.org. And thank you all so much for your time.
All right. Someone would like to know what efforts are being made from CFF to expand support groups and resources to diagnoses of CRMS and CFTR dysfunction.
Yeah, that's a great question. I can't speak to that myself, as that is not really under my purview, but I know that that is something that we look at as program options for things, and each year we look at what topics are available and needed and reassess who we serve.
And someone would like to know, do new CF mothers tend to make use of Peer Connect or CF Circle groups? This could be really valuable for them.
Absolutely, great question. And 100% want to shout out CF Peer Connect. That's sort of a sister program of ours. And new mothers absolutely use CF Peer Connect. It's a really terrific way for them to be able to connect with others, especially those who are going through the same thing or have already gone through it, to share their experiences.
And along with the consistent theme that we've had across all of our presenters today, someone would like to know if there are plans to offer similar opportunities for children or adolescents to meet online. They have mentioned that their 12-year-old with CF has only had 1 or 2 interactions with other kids with CF in their life, and it's a major gap.
Yeah, absolutely. That is not currently something we're able to serve, just based on the sort of consent ability with that age group. But I will once again mention that CF Peer Connect goes down to 16. So, up until that time, that Peer Connect is probably the first place that I would suggest they go. And then the caregiver could absolutely join some CF circles.
Something to maybe consider expanding to. Someone would like to know if the CF Foundation has flyers on community circles that people could post in their clinics.
Yes, we do. Please email me and I will send it to you. We update them quarterly with the information, so they're really timely. We create new ones each quarter. So yes, absolutely happy to email that to you.
All right, with our remaining time, we've got about 15 more minutes. We'd like to invite all of our speakers up to answer some of the remaining questions that we weren't able to get to earlier. Okay, so I believe that this question was related to the GEMS questionnaire. Someone was wondering if about just asking open-ended questions instead of doing a general screener, as a lot of patients have different levels of functioning.
Oh, that's a great question. You know what we have at the end of the GEM screener is other. And so we sort of also ask the last item, any issues adjusting to life on a modulator. And that really gives them an opportunity to bring up a diverse array of issues that are bothering them. And so we do have that opportunity for open-ended questions. I also really messed up the answer to that last question I was asked. So just to go back for a second, how do you tease apart PHQ-9 depression or anxiety on the GAD-7 from the GEMS? And what I do is not just look back at history, but I ask them, do you think this mood change is related to your modulator? And sometimes they'll really say, oh no, I've had this low-level depression for a long time. This isn't new. It didn't change, even if they started a modulator earlier. But I have to issue a caveat. Over the last year, we had 2 women who had a very mild history of depression. They've been on modulators 4 years. They suddenly had an escalation of severe depression and suicidality. One was hospitalized, and we thought it was related to the modulator. We took them off the modulator. Their mood stabilized completely. Then we put them back on very low doses to get back up to close to full dose. So you can even have these mental health changes from modulators later, even though you started it 3 years ago. We have seen a few people emerging with side effects much later.
Thank you. And then, oh, sorry, go ahead, please.
Oh, I don't have to preempt the app. My question is for Amanda Bruce. So I can't really, sorry.
I can stand it.
So I think I can probably anticipate your answer, but I was thinking about it when you were talking, because I think that the answer is just the validation is so important. But I'm curious what your experience was in sort of selling people on a psychosocial intervention for pain, because I feel like there's so much around people feeling like anything that of that vein would be saying that the pain isn't real, right? I mean, obviously there's so much education in the intervention, but like, even did you have any struggles getting people to agree to it? You know what I'm saying? I can see you.
Like the whole pain's all in your head.
Yeah.
Right.
Yeah.
We didn't have a lot of concern about that. Possibly, framing it as coping strategies, skills to just some techniques to help manage day-to-day life, right? And And I think acknowledging up front and validating their pain, like, we believe you, your pain is real.
Yeah.
We're just going to provide hopefully some other strategies that might help.
Yeah. I think it might also be like one of those beautiful things about the CF community. Like, I feel like they're willing to do stuff and we have their trust. I work with other disease populations that I feel like it would be a much tougher sell because they've been, you know, like autoimmune, like people that have been brushed off by providers. So it's just like a nice thing about our community. I was like, this probably isn't even an issue for you.
Yeah. Thanks for your question, comment.
Okay, and then Amanda, people were also interested in your experience with opioids in chronic pain. I don't know if that is a question that you feel like you can answer, but I know there was some really good information on that in a session that occurred yesterday. The big pain training that was held yesterday was touched on that some. I would not feel comfortable repeating any of that information, but there was some information on that.
So opioids are tricky, right? The pendulum has definitely swung towards trying to reduce use, especially for people who are ultimately headed towards lung transplant, right? So they don't want people on opioids. Opioids can cause, respiratory depression, and they can cause constipation for people with already kind of compromised GI systems. And so, I think they're prescribed, and different providers feel more or less comfortable prescribing them. We do have patients at our center who take them, but many who have chronic pain who do not. I don't know if that answers the question, but
Okay, and then someone was really interested to hear more about the high rates of the reported ADHD symptoms in the GEMS study, especially with it being an adult population. And they were curious if you had the opportunity to look at reasons for attention difficulties like mood, sleep, or fatigue.
That's a really wonderful question. We believe that ADHD is more common among people with CF, both in pediatric population and the adult population. We don't know why, but if you look at the single center studies, there have been a consistently higher rate of ADHD in people with CF than in people who don't have CF. So when we do GEMS at a national validation level with 250 adults, one of our goals is to estimate the prevalence. So we are giving an ADHD measure as one of the convergent validity measures, and having 250 adults representing a national sample will give us the first big study to estimate the prevalence of ADHD. When we queried this further, often they said, I started having ADHD symptoms as a child, but my parents couldn't afford to get me evaluated, or they never took me for treatment. I struggled with this as a child and in school, but nobody really addressed it, especially because I have CF. That sort of took the forefront. So that's another reason I think that GEMS is so important, is that, first of all, people are doing much better on modulators. And so if they're struggling with ADHD, we ought to be there to help them with that as well. So it sounded like many of them had a long history from childhood into adulthood, and we're still struggling with those ADHD symptoms.
Thank you. And then, Amanda, I'm sorry to make you keep standing up. Maybe we could pass the microphone to you so you don't have to. But this is a long question, several parter. So let me know if there's any parts you want me to repeat. Maybe we'll just tackle it one at a time.
okay.
So someone would like to know if there is plans for the future to compare PACE to other treatments for chronic pain.
That's an awesome idea. Ultimately it probably comes down to funding, right? Like, would we be able to fund a project like that? It would be great. I think really interesting. Compare it to mindfulness, compare it to yoga, compare it to behavioral activation and exercise. Yeah.
And then is there any preliminary data that suggests that the pain experience itself is different for those with CF than other chronic pain populations?
Another amazing question. And we collaborate with an anesthesiologist who does quantitative sensory testing. Like, that is her expertise, Andrea Chadwick. And so our next grant application would attempt to answer that question and see, from a more objective perspective, how is pain represented for people?
Great. And then finally, the last part of this question is if there's any data about incorporating a behavioral pain treatment post-hospitalization to possibly prevent developing chronic pain or worsening pain functioning, kind of similar to like a transitional pain service.
That sounds amazing. I mean, I think that, not just for CF, I think a lot of people post-hospitalization could use that, right? Coping and, behavioral activation. So great idea.
Do you have anything that you wanted to add, Annie? All right. Well, this has been fantastic. We really appreciate you all. Oh, yeah. I can repeat it into the microphone if you want, or you can step over here. It's being recorded, so we just got to make sure that it gets captured. But I'm happy to repeat the question into the microphone if that's helpful. So the question was kind of summarized is, for the peer CF circles, was there any kind of person on standby for if there were any sort of disclosures of crisis or things like that, and how that was managed?
Excellent question. Yes. So sort of a two-prong approach. One is we are in constant contact with the facilitators as they are facilitating for them to be able to share with us if there's something maybe they're concerned about. We have sort of a separate private chat that is happening at the same time that they can share. This person might need an outreach afterwards or something like that. We also have on our team a licensed social worker who is available to help out right there in the moment. And in addition to that, we have risk assessment protocol that we go through if there is something that we are concerned about. And we are fortunate to have relationships with lots of these folks. So we're able to reach out to them afterwards if we feel that they might need some kind of assistance.
All right, wonderful. Well, if there are not any other questions, we would just like to thank all of our fantastic speakers today. We really appreciate you sharing the fantastic work that you're doing with everyone and doing that work. So yeah, thank you.